Now, physicians are sort of, in terms of patient satisfaction, we often find ourselves in the position of this rich fat cat sitting in the back of the long limo. There's been an accident, but it doesn't involve me. Physicians have a remarkable way of depersonalizing the feelings of our patients about the delivery about the medical care they deliver. Now, we all understand that we are not the only ones responsible, but I don't know if you have the same feeling I do. I walk into a patient's room, they've just had a renal artery revascularization or leaving the hospital on day 3, and they say, well, that was all right, but the food really wasn't very good. Now, my reaction to that is, oddly enough, I explain to the patient, I really don't cook the food at the hospital. But the fact of the matter is that it just demonstrates the different perspective that a patient has on the whole experience. And they look to us, as since we call ourselves the captain of the ship. So patient satisfaction really does involve us. Let me just tell you one story from my experience, which focused me on this about 10 or 15 years ago. I had a very elderly male who had a 8-centimeter thoracoabdominal aneurysm. He had very severe pulmonary disease, such that we thought that at that time the thoracoabdominal incision was not attractive. And we made a decision not to operate on him. However, he developed impending rupture, severe pain. His wife brought him into the emergency room, and it was very clear that either we operated on him or he's going to rupture his aneurysm and die. So true to the sort of direct approach, which I know is utilized here in the past with great success, we did a thoracoabdominal approach, restored continuity, plugged in his intercostals, did the whole thing, and it's sort of a vascular surgical tour de force. And the patient did remarkably well. He survived the surgery, had no renal failure, he had no significant spinal cord problems. He was in the ICU for 10 days, which was about what we expected on a ventilator. He was in the hospital for another week. Following completion of that, he was transferred to a rehab setting and discharged home after 4 weeks in the rehab. And then I scheduled him for a return visit to my office. And I was just proud as I could be that this 87-year-old gentleman with these considerable risk factors had tolerated and recovered through this procedure. And the patient walked into my office, looked like $1 million to me. I was patting myself and him on the back when he told me that in retrospect, if he had to do it, he wouldn't have done it. That the suffering for him and the suffering for his family was too great. And at 87 years, in retrospect, it wouldn't have been the decision he made. And I must say that one could quibble with the logic of that, since he went on and lived at least another year or two that I know of. But the fact of the matter is that was a genuinely held thought, and it was markedly discordant to the way that I felt about the success of that operation. So what I learned from him, and what you doubtlessly have learned from your patients, is that despite the best intentions that we have, patients enter treatment of surgery with inadequate understanding of the process. They may have discordant views of what a good outcome is. And understanding this communication interface between doctors and patients remains challenging.